Right. Good morning, everyone. Good morning, everyone. All right. Welcome to our Define Forum. This is the first time that we've had one of our quality improvement collaborative meetings here, and it is a very cavernous space. So I thought instead of me standing over there, separated from you all, I'll just stand a little closer. So for those of you joining virtually, thank you for joining us. They are working on the camera so that you're not staring at a blank spot on the podium. So my name is Susan Huang. I'm a neonatologist here at the Anschutz Medical Campus, one of the physician leads for this Quality Improvement Collaborative. It's so nice to see all of you here this morning. I know we're all here for our own unique reasons, but I hope that this day is really enriching and engaging for you all. They are going to work on getting me a slide. All right. So, for those of you here in person, raise your hand if it's your first time attending. Whoa, it's about half. And repeat, folks? All right. Raise your hand if you work in a hospital. Raise your hand if you work in a public health organization. Raise your hand if you're a family member. All right. Well, you should all raise your hand. You're all part of the family, but all right. Let me stand up here and advance slides. Oh, perfect. All right, so before I get going, I really do have to acknowledge the folks here on this slide whose names are listed that's made this possible. Rebecca Guili, who is standing outside, she leaves no detail unaddressed, truly amazing. Emily Fawaz, Sarah Cahoon, our family advocates, we couldn't have this forum without you too. Blair, our data person, every year allows us to look at our data and be data-driven in our interventions and outcomes. And then Brace Gibson from CPCQC, I think she's outside, who also has been instrumental in making this happen. So, introductions. Any Nuggets fans out there? Woohoo! Yes, yes, yes. So this was great. So this is, when they introduce the speakers, the players, and they all come out and high five. So this is them. So, briefly, what I wanted to touch upon is, the great content that you all receive and hopefully contribute today. I really want this to be a bi-directional flow of information and experiences. And so I'll start off with some brief opening remarks, share some data with you all about the defined process and outcome measures. We'll have our keynote given to us by Dr. Heather Burris, followed by our second keynote by Kyler Romeo. Is Kyler here? I hope, or she might be joining virtually. Okay, I'll have to check that. We'll have a brief break, and then we have our parent panel facilitated by Emily Fawaz and Sarah Cahoon. We'll have lunch, and then we'll have an update from our state about our family and medical leave insurance program. And it's been approved and put forth, but I think very few of us actually know the details of it. And I think it'll be important for us to share this information with the families that we serve. And then we'll have our hospital-based presentations, followed by the Annie Hall Award, and then some brief concluding remarks. And so I like to ask this question: why are you here and why am I here? This is not a, esoteric philosophical question, but for those of you that are here, I know that doing family engagement work is not paid work. This is work that you do voluntarily above and beyond your allotted FTE, particularly for the clinical folks in the room. And so we're all here with different motivations. And last year, I shared with you this picture. This is the first professional picture that my family took after immigrating from Korea to the US. And what I shared with you last year was that what motivates me for this work is that I recognize that my family had very little. I experienced a lot of adverse childhood experiences, and yet I can stand here today and share with you all the good things that I'm experiencing and that I've been able to give back to this profession. And it's because there were systems in place that allowed this to happen. And so fast forward 40 years, these are my girls, Sonia and Lucy. And I share this picture with you because they don't look East Asian, right? So I married a white man from Wyoming, and hence we produce children that look like this. And I've been thinking a lot about how they walk through their lives and how different it is from how I walked through my life. I was an East Asian appearing immigrant, and they, while they are half Korean, don't appear very East Asian as I do. And they navigate life so differently than I did. And it's not because of anything they did or didn't do. It's really because they look the way that they do. And so they are not going to experience some of the very negative experiences that I had as an East Asian minority. They walk through life very differently. And again, it's the systems and structures, the hierarchies that are in place that allow them to navigate their life probably more easily than I did as a child. In fact, last night, Heather staying with me, she comes down the stairs and hears this conversation that I'm having with my 8-year-old Sonia, because at her school, they have a special meeting for children who identify as an individual of color so that they can discuss in a very nurturing kind of community the experience of being an individual of color. So I asked Sonia, is that something that you would like to participate in? And she said, well, I don't think of myself as a person of color. Oh my God. Okay. And so I'm not going to force her to participate, but it was just this moment where I realized she walks through life so differently than I did. And again, it was nothing that she did as an individual or didn't do. It's the system that is created around her. And so while we work to dismantle systems that perpetuate inequity, I think we're all here because we also find meaning and value in our relationships. And so Sarah, I just told her that I'm going to share a picture of her, and I got consent like 2 seconds ago to share these pics. So these are pictures from Love for Lily's Boots and Bling fundraiser that occurred fairly recently. And so shown in both of these pictures is a neonatologist, Erica Mendel. She's not here right now, but she's an associate professor. She's a basic scientist. She also leads our clinical care team focused on care of infants with very severe bronchopulmonary dysplasia. Now, Sarah and Erica had not seen each other since Erica had just started her attending life years ago, and when she took care of Sarah's baby, Lily. So it had been such a long time, and they reconnected here. Separate picture from the same event. Where's Lanny? Lanny over there. So this is Lanny and Erica also have not seen each other in quite some time. And Erica's, one of her 2 daughters was actually in the NICU. And they're sharing the story about how Lanny taught Erica's husband how to change the diaper while the baby was in the NICU. So there are these very enriching personal connections, I think, that we can establish through this work that continue to, I mean, as corny as this sounds, kind of feed our soul, right? And motivate us to continue to show up. And so I really hope today you have lots of enriching conversations. And while we think about systems level barriers and facilitators to supporting our families, it's real important to make these individual connections and be enriched by each other's presence. And so this is the definition that we define have choose to adopt. You know, there's no accepted definition of patient or family engagement, but this is one that's really informed our work. It's a set of behaviors by patients, family members, and health professionals, and a set of organizational policies and procedures that foster both the inclusion of patients and family members as active members of the healthcare team and collaborative partners with providers and provider organizations. There are individual level actions, there's organizational, and I would say probably not included here, community level factors that influence a family's ability and desire to engage in this way. But truly, families are collaborative partners. And that's really represented here. How do we move from the far left, where we have our very traditional paternalistic model of healthcare, where the healthcare team is acting upon or informing the patient or family? We've moved on to patient-centered care or family-centered care, where the family is at the center and the healthcare team is around them. But really, I think what we're hoping for is partnership of care, where it is family-directed. They are both part of the team, but also informing the actions and the care delivery of the team. So this is really the goal. How do we achieve partnership of care, even moving beyond family-centered care? You know, that parents are really, really effective champions. They're passionate, active agents, and they have a personal stake. These are folks with lived experience whose babies were in the NICU, and they have a lot to contribute, and they can certainly influence and inspire action in others. And we'll hear about that today. All right, so this is our key driver diagram. You guys know this, or I hope you know it, but really importantly, this is our aim. That we hope to improve parental report of engagement in infant health and development during NICU hospitalization by 20%. Equally as important, we seek to reduce disparities in family reported engagement. by race, ethnicity, primary language, and distance from the hospital. And so critical to these aims are that we are using parental report. These are parent surveys that are determining whether or not our collaborative is successful or not. This is not from Epic. This is not from other hospital records, but really parent report. And equally as important, and perhaps even more so, this is an equity-focused quality improvement collaborative where we seek to reduce disparities. All right, so I'm going to move on to the data report. And I'm already behind, so I'm going to really go through this very quickly. For the hospital teams who have been contributing data, you receive your quarterly data reports as well as the collaborative level data. So this should not be a surprise to any of you. Listed here are the 6 hospitals that are presently contributing data. If you are a hospital that's not listed here, come see me and let's get you signed up. All right. So since we started, we've enrolled 495 families. There is some chart abstraction that takes place by the Defined Hospital team. We have 314 that, let's see if I can make this work. Maybe, yeah. 314 of families that complete the survey enrollment. So this is that survey that's administered, just within a week or two of admission to the NICU. Now, this is where the big drop-off occurs, where then we move on to the pre-discharge survey. So this is happening about a week or so prior to discharge, and then we get down to 140. So I know that we've identified a lot of issues going from here to here, and I know it's a continuous work in progress. And then post-discharge, this is our 1-month post-discharge survey. We have 116. So when I think about going from pre-discharge to post-discharge, I think that's a fantastic response rate, recognizing that these are families that are completing the survey when they're home, a month after they've just taken their NICU baby home. So I think that's a phenomenal response rate. We collect some demographic information here on the right. You can see that the majority of respondents are identified as mothers at 88%. And you can see that about 60% have male babies. In terms of race ethnicity, the majority of our group are white, which reflects our birthing population here in Colorado. That's not that racially diverse. But what's interesting is that there is a difference between what parents report as their own race versus the infant's race. And so oftentimes in our electronic medical records, what we see is maternal race, particularly for birth hospitals. And that actually may not align with the infant race. And we see that we have, several who report more than one race. In terms of ethnicity, we know that we have a large Hispanic birthing population here in Colorado. And again, you can see that reflected in our data where we have about a half to a third that identify as Hispanic. Let me skip through this. We track average length of stay by quarter of admission. And you can see that on average, our babies are in the NICU for about 2 months. I share this with you. This is not, a good thing or a bad thing. It is just a fact. But I think it's important to know that this is 2 months of opportunity to engage with these families. It's 2 months to understand their experiences, provide the supports and services they need in order to transition home safely. In terms of language spoken at home, you heard me mention that reducing disparities by primary language is a priority. We can see that the majority at 86% are primarily English speaking, and then we have about 5% Spanish and then 6% English and Spanish. In terms of infant insurance, the majority are publicly insured. I don't necessarily take this as a proxy for socioeconomic status, recognizing that once a baby is admitted to the NICU, even those that are privately insured will gain some sort of public insurance to offset the cost of such an expensive hospitalization. Transportation, the majority of our families are driving by their personal car. If we look at the travel time to the NICU, about half have a commute that's about half an hour. We have some that are half hour to 60 minutes. And then we've got some that are driving a fair amount. And so in this large catchment area, in the Rocky Mountain region, I think transportation and the time taken to see their babies is certainly a barrier. So we have 4 key drivers. I'm going to share just limited data on a couple of them. The first one is focused on communication. Here we're looking at a parental report of a scale. How much effort has been made to help you understand your infant's health issues from 0 to no effort, 4 to every effort? And so the top is at the time of enrollment, about a week or two after admission. The bottom is just before discharge. In general, our families report very high levels of feeling informed about their infant's diagnosis. But when you stratify it by race ethnicity, we start to see some signals. Now, these numbers get a bit small, and you can see here that for the racial breakdown, we had to separate by white and non-white because our non-white group is so small, we can't stratify that further by, say, Black or Asian. And so in terms of ethnicity on the far right, you can see that interestingly, non-Hispanic families perhaps report a slightly higher rating of being more informed around their infants' health issues. And then in terms of race, interestingly, pre-discharge, we see white families have a lower rating compared to non-white. And then rural urban residents, I think, is fairly similar. Here we have parents are asked, have you had enough input in your infant's care? 0 to 3, 0 being no, 3 meaning yes, definitely. And in general, you know, I think our families feel that they are included, that they have input in their infant's care. And then when you stratify it by race, ethnicity, as well as rurality, we're not seeing big differences, right? So I find that to be relatively reassuring. How often have you felt like a parent? So these questions, you know, feel a bit vague. I would imagine to the, you know, the quantitative analysts in the room, I'm looking at Venice and Heather, you're like, what are you trying to get at these questions? You know, and part of the problem is we don't have validated questions that measure family engagement in the NICU. So these are the questions that we picked for our collaborative. And so here again, families in general report most of the time or always they felt like a parent in the NICU. And then we stratify it by race, ethnicity, and rurality. Again, pretty equal, no major differences, reassuring. Parental burdens and challenges. So we ask families, you know, how often are you feeling worried or stressed? And so this is demonstrating families who report either always or often about these specific things. In sky blue there, it's, whoa, okay. In sky blue, here, this is at the time of enrollment, shortly after the baby's admitted. And then in red, it's just before discharge. And you can see that the things that families are most worried about are bills, transportation, childcare. Now, food, I've highlighted a lot in prior defined meetings. A family who comes to the NICU to see their baby should not worry about food. Right? This is like such low-hanging fruit. And I wish I could tell you like 2 years after looking at this data that we've come to a solution in our NICU about providing food at regular intervals to families, but we still haven't gotten there. And yet it's such low-hanging fruit. There should not be a single family that worries about food during their NICU hospitalization. And then here is a list of other challenges while in the NICU. And so what I find reassuring is that in blue, this is at enrollment, and yellow, it's prior to discharge. It goes down. And so I give major props to our bedside nurses, our social workers, our case managers that work closely with families to address these other social determinants of health, these factors that are certainly going to influence the well-being of that infant and the family post-discharge. I'm going to skip through this because we are very late. All right, safe infant sleep. This is one of our key drivers. This is what our hospitals have selected as the focus of this fiscal year that we're focusing on. So here's some of the more recent data. So here we have on the dark, I don't know, teal, that's parent report of what they're seeing in the sleep area. So at the time of enrollment in the NICU, and then just before discharge. Ideally, just before discharge, families shouldn't be seeing anything unsafe, right? In the sleep area, if truly we're being adherent to safe sleep. Now we could see that the percentages go down, which is good. At the time of enrollment, babies are really sick and we got to do what we got to do to stabilize them. But still at the time of discharge, families are reporting, you know, burp cloths and some stuffies and some blankets that are in the cribs. Here we have infant position, and this is stratified by what families are reporting 1 month after discharge in the home. So here in yellow. So you can see that the majority are doing supine positioning, but at the time before discharge here, this middle bar, they're still observing, you know, some unsafe sleep practices. This is our process control chart over time around overall safe sleep compliance. So parent observation at the time of enrollment, at discharge, and then post-discharge home. And I think there's an upward trend. right? So most recent 100% of families, reporting overall safe sleep compliance. So we'll see if this continues. But I think what's still not optimal is that pre-discharge, right? Just before discharge, our hope is that families report they're seeing real adherence to full safe sleep practices. And this is why our hospitals are engaged in this work. All right, this is overall safe sleep compliance by hospital. So 5 hospitals that are sharing data for this particular key driver. What I find so interesting about this slide are 2 things. One is, we all kind of suck, right? But there's not a lot of variation. I did this work in Massachusetts and the numbers were all over. Even at the start of the collaborative, there were some hospitals that were 90% compliant with safe sleep and others that were like 20%. But our 5 hospitals are pretty similar, both at times of enrollment, pre-discharge, and home. I mean, clearly we still have a lot of work to do, right? It cannot be that less than 50% of our high-risk NICU families are reporting that they are being compliant with safe sleep. This is even far below estimates from the full-term population. Okay, so for next steps, for those of you that are not yet engaged in this effort, please reach out to us. We'll send out a business use agreement or a data use agreement that allows you to share de-identified data with our group. We'll provide training to your hospitals, do site visits to get you kind of ready. And really, our hope is also that we go beyond the hospital and think about engaging with other community organizations external to the hospital. The success and the well-being of our families at the end of the day, doesn't reside with us entirely in the hospital setting. It's really how they can be supported, after discharge out in the community. And so it's real important to think about partnerships with these other organizations. And we're just starting to think through that. All right, with that, questions? All right. So now I'm going to switch here. Now, I have the pleasure of introducing my good friend, Dr. Heather Burris, who is one of our keynote speakers. So Dr. Burris is an attending neonatologist, Children's Hospital of Philadelphia, and associate professor of pediatrics at the University of Pennsylvania Perelman School of Medicine. She studies social and environmental factors that contribute to perinatal health inequity. She has a long list of projects for which she is the principal investigator. She is NIH funded, incredibly well published, and she is a national expert. And so we are so fortunate that she is able to spend time with us today. Now, I can read through all of this, but I think what's most relevant is a story that I will share about, and I don't think she even knows that I'm going to share this. This is how much I admire Heather and how brave she is. So many years ago, this is before COVID, right? When we are gathered at this very large neonatology conference that we call Hot Topics. It's like over 1,000 neonatologists that are gathered in the room in person, because this is before COVID. And this is when I would say the majority of our field were very early in our equity journey. We had not yet experienced the inequitable outcomes of COVID or the George Floyd murder. We are early in the equity journey. And Heather gets up as the keynote speaker and she lays it down. She explicitly stands up in front of this group of, I would say, majority white neonatologists who probably have certain political leanings, and explicitly states that racism is why we have these different outcomes amongst these groups. That while we tend to sugarcoat it and talk about racial and ethnic disparities, she explicitly said it is racism. And she goes through and makes a point by point kind of argument for why it is racism. It was so brave, and I don't think ever done in that setting. So that's the story I will share with you about Heather and how much I admire her and how brave she is. So thank you, Heather, for coming.
All right, let's see, which is this on now? No? Yes? Yeah. There we go. Okay. Susan's always a tough act to follow. And thank you so much. I promise I will not give you a solely racism talk, but there might be a little bit sprinkled in. And thank you for bringing me home. I was born here in Colorado General Hospital, I believe it was called at the time. My dad was a pediatric resident in the mid-70s, and I moved to the East Coast at age 1. So it doesn't really look familiar to me, but maybe there's some piece of me that still remembers the dry air and the beautiful mountains. So thanks for the opportunity to come and share with you. Let's see, is this going to just advance or? Yes, it is. Okay. So I'm here to share with you a passion project. So Susan mentioned some of my funded work around social and environmental determinants of health. But this is really that midlife crisis of, oh my goodness, I can't just describe all of these inequities all the time and blame everyone with the racism word. We have to do something. And I think all of you are doing many of the somethings. And so this project is one of the somethings that our group is trying to do. So I have a little bit of funding for this. This is kind of in pilot funding land. And so you'll hear about this trial, which is funded by 2 organizations up here. But I think probably most important disclosure is really the lens that I bring to this work. So I'm, as Susan mentioned, a neonatologist and a public health researcher. I'm a feminist. And so every time there's the Women's World Cup, we hop on a plane and bring our girls, and including this summer, we went to New Zealand and it was amazing. So I have a lot of privilege. I'm white. I'm a soccer and a swim mom to 3 middle school, early high school age girls. And I'm a witness to a lot of trauma that is not my own. And so it's really important to partner with folks who have shared lived experiences with our NICU families. And obviously you're walking the walk on that. So I start my talks with all of the gratitude, and this is the subset of human beings that work with me on what we call the postpartum care in the NICU trial, or Pelican. And they bring just such expertise. And I'm going to be particularly highlighting the 3 women on the top, your top left, who work on the project on the ground with NICU families. So I know here when we talk about NICU, we're often thinking about babies, and we think about infant mortality or preterm birth. And we have not just a baby problem, but we have a birthing parent or maternal health problem in this country, and it's growing. So whether you're on social media or print media or any place, you're going to see large increases in maternal mortality. And every few weeks, there's another study that comes out to try to kind of describe this and try to think about drivers that could improve this kind of shameful outcome, given the resources our country has. And the maternal mortality rate has more than doubled. This is per 100,000 live births in the last 20 years. And while every other country seems to be getting better, this is from OECD data, we're getting worse. We're better than some, but not that many. So among the OECD countries, we're in the worst 5. And we have massive inequities. So just like with preterm birth and what we see in the NICU, there are massive inequities when it comes to race and ethnicity with respect to maternal mortality. And you folks might be seeing some of the American Indian, Alaska Native populations on the leftmost bar. In Philadelphia, we see primarily a Black population that is experiencing a lot of health inequities. But these rates are 3-fold what other folks are experiencing. And most maternal deaths happen postpartum. Okay. So I don't know if any of you watch Downton Abbey, right? Like every time you watch a movie and it's about maternal death or somebody's dying, it's always in childbirth. I feel like we're not really thinking about the postpartum period or even the antepartum period, but most maternal deaths happen postpartum. And, if you think about that length of stay slide that Susan showed you, that's when it's happening. We're there, right? We are there with some of these families in this postpartum period. And death is kind of the tip of the iceberg, right? There are a lot of morbidities that are also happening in the postpartum period. And there are many, many causes of death. I'm going to highlight the top 3 here, which are mental health challenges and disorders, hemorrhage, and then cardiac condition. So I'm not sure we're really that good at handling hemorrhage in the NICU, but we can certainly help when it comes to the mental health conditions and maybe even the cardiac conditions, right? At least for screening and referral. So I thought everybody went to their postpartum visit. They don't. Okay. So only about 2 out of 3 individuals go to their postpartum visit. I'm a box checker and I liked getting A pluses. So if you told me I'm supposed to go to an appointment, I always went, however inconvenient. But that's a little bit also my privilege, right? I had the bandwidth and the ability to get to all of my postpartum visits. But there are definitely missed opportunities to help people. And so ACOG, so the American College of Obstetricians and Gynecologists, has come up with more of what they call a woman-centered or birthing parent-centered plan, such that instead of that traditional just one visit at 6 weeks, you can see on the bottom of the slide, let's see. Yeah. So the old traditional was that, you had your baby, you rested for 6 weeks, but you're 6 weeks at home and then you go to your 6-week postpartum visit. And they recognized that a lot was actually happening in that 6 weeks and people just dealt with it. But there are really, especially with high-risk individuals, opportunities to really intervene early. So blood pressure checking in the first about week and a half, and then follow-up risk for high-risk folks in the first couple of weeks, and then really tailoring the postpartum care for the individual. But that still requires people to show up, right? So if we're still only showing up 2/3 of the time, we're missing a huge opportunity. So that's nationally. Then you have to think, okay, well, what can I do? And I'm not going to solve this for the whole country, but let's think about this locally in our own unit. And so like here in Denver, we have multiple hospitals in Philadelphia, and we as neonatologists work in our group at the Penn Medicine as well as the Children's Hospital of Philadelphia, which are right next door to each other. And so Penn Medicine is really the place where most people give birth. I'm going to talk about childbirths in a few minutes, but I was able to pull our Epic data and look how many people who were getting prenatal care, and so that's where you would expect them to get postpartum care, how many of them actually went to their postpartum care visits, and we're at about a 40% rate. I had a hypothesis that maybe that was all the resident clinic and that people just didn't know their doctor and so they didn't care about showing up. Nope, it's not that, because they're not going to their faculty practice either. So we're at about just well under the national average. So we really have a problem, and we have a lot of sick parents. So then the question is, what can we do? What can I do, right? Like who can I invite to help? How can we solve this problem? And what is my sphere of influence? And what can we kind of do to interrupt this? Because we know that NICU birthing parents are particularly high risk, and I'm in the NICU. Is there a way in which we can kind of try to tackle this? We know that NICU birthing parents, people with preterm birth, are more likely to have a subsequent preterm birth. We know they're more likely to have cardiovascular conditions because, all the preterm births that we have, they're not all the same, right? Some people come in with rupture of membranes, spontaneous contractions. Other people come in, they thought they were fine. They get a blood pressure check. It's through the roof. They've got protein in their urine. They have cardiovascular disease, preeclampsia, right? The folks who had preeclampsia or poor placental function for whatever reason are at way higher risk of cardiovascular complications postpartum, right? And we see these parents. And we know also that having a baby in the NICU, so lots of people have mental health conditions coming into pregnancy, but then if you have a baby in the NICU, that's even going to potentially exacerbate those pre-existing conditions or uncover conditions we didn't know were there or trigger them. And so there are opportunities to help, and at least in Philadelphia, very few resources to help these parents. And so I want to tell you about how so I wasn't thinking about maternal mortality as a neonatologist. I think most of us don't. But in 2017, I moved back to Philadelphia from Boston. And it was a Saturday morning, and I was rounding with a nurse practitioner, and I, had gotten sign on my 16 patients. It's usually a pretty quick deal. You're in and out in just a few hours on a Saturday morning. And I walked into the bay, and there was a parent next to her baby. The baby was very, very sick. Had meconium aspiration, term baby, meconium aspiration, therapeutic hypothermia for concern for brain damage from a traumatic birth. And so, we know how to do that. I'm worried about the baby, but I know what to do. So I'm not particularly stressed about that. But she looked really green. And I thought, well, maybe it's the backlighting, because there was a window. And I thought, well, maybe she's, and so then I kind of go closer and I'm turning, and now the window's behind me and she still looks green. And I was like, oh, good. I don't take care of grownups. Like, I don't know what to do here, but I was like, are you okay? And she's like, I don't feel good. And she was in a fair amount of pain. And then she lifted her shirt, and this is not her incision. These are stolen photos from Google, but she had a terrible looking incision. And I thought, oh, okay, this is bad. But there are people here at CHOP who take care of grownups because we have a birthing population at the children's hospital, like you have here. We have obstetricians, we have midwives. I thought, I'll just call them and they'll come see her and everything will be okay. No. So I called and they were, oh, sorry, she's not one of our patients, right? She didn't give birth here, right? So Philadelphia, like Denver, has a large catchment area of not just people who give birth with us, but people whose babies get transferred in. I think your transfer in situation's even broader than ours. But this parent had come from New Jersey, the Jersey Shore. So about, no traffic, which it never happens, but no traffic, maybe an hour and a half, like with traffic, you're talking 2 to 3 hours. And so my alternative was to send her to the ER, which we did. And 18 hours later, she came back with her prescription and her antibiotics. And she missed 18 hours with her critically ill baby. And can you imagine what was going through her mind? Like, really? Like, Dr. Burris could have written me a prescription for this same pill. Now, that's out of my scope. I don't know how to do that. But we have to overcome these barriers, right? And it's going to be a multi-pronged effort that's going to require payers. It's going to require administrators. Because guess what? Even though she's not a CHOP patient, if we need something from her, like her genetic material, we find a way. We get her a medical record number. We figure out, we register her. Why can't we do that? Right? We can't. It blows my mind, right? And it's probably because of the money, right? It always comes back to the money. Okay. So back to the cycle here. So sick parents, right? Let's see. Sick parents with gestational diabetes, hypertensive disorders of pregnancy are more likely to have NICU babies than the general population, right? Sick parents are more likely to have sick parents. Now, there are plenty of healthy people who also have complicated pregnancies, but if you're just talking about risk and proportions, sicker people are more likely to have a baby in the NICU. Then we add on top of that, being a NICU parent is traumatic, right? And it can trigger a bunch of mental health concerns. Then postpartum parents have unmet healthcare needs. Okay. And that can lead to worse health. And then poor maternal health may lead to a subsequent bad outcome for the baby, bad next pregnancy outcome. And parents prioritize being with their babies over taking care of themselves. So this was where Pelican was born. It was really to try to interrupt this cycle, right? Can we provide postpartum care in the NICU? Is there a way to demonstrate that it could be effective? And ultimately, will we get to the point where you can't say you have a good NICU unless you take care of the parents too? So the situation, we have a maternal mortality crisis. NICU parents are in the NICU for a long time during that captive, really important period. And 1 in 3 parents, and maybe more if you're in Philly, aren't receiving postpartum care. So we see the NICU as a novel site for postpartum care delivery. And so our hypothesis was that compared to usual care, a doula-coordinated, midwife-delivered postpartum care in the NICU program or model would lead to increased rates of postpartum care receipt, and then maybe some improvements in secondary outcomes also. So health-related quality of life, maybe mental health. So we take a moment on doulas. I don't know how, is anyone working on doula programs here in Colorado that you know of? Program, yeah. So it's a big deal on the East Coast. New York City, Brooklyn has a big doula program. Philadelphia is developing one. Most of it's focused on the pregnancy and birthing period, although doulas also have some expertise in helping people in the postpartum period. So if you have a lot of resources and you hire a doula, the doula can also help you in your home after you give birth and help you with kind of dealing with your breastfeeding and meal prep and making sure you get sleep and all of the things that can help with. But the trouble is that doulas are often not paid for by insurance companies. And so it's usually the people I know who have doulas tend to have lots of money around to be able to pay for them. But doulas are trained professionals who provide continuous physical, emotional, informational support to achieve the healthiest pregnancy outcomes possible. And they work with parents and families as really with direct in-person support that is really patient-led. So that was the goal of bringing doulas specifically into the NICU, not just community health workers, right? People who are truly focused on the birthing parent or the mother. And then we decided to invite a certified nurse midwife into the NICU. Now, I got to tell you, this is embarrassing, but I didn't really know what midwives were. I think I had this was years ago. I remember thinking that these were kind of lay people who just kind of help you have a home birth. I mean, I did not realize that midwives were nurses with specialized training, just like our NICU nurse practitioners, right? These are people with specialized training around pregnancy, birthing process, and reproductive health, women's health generally. So these are really the midwives that we invite into our NICU are certified nurse midwives. These are advanced practice nurses with specialized training. And together, the data show individually and then together, doulas and midwives very often are shown to have improvements, reductions in C-section rates, improvements in lactation, less postpartum anxiety and depression. So again, just kind of this like general whole well-being support. But we don't know their impacts on really the postpartum healthcare receipt. And we know for a fact that their presence in NICUs is really rare, if not totally absent. And so the study procedure for Pelican are that parents are randomized within the first week postpartum to either usual care or a doula midwife pairing. If a parent really likes their own obstetrician or their own midwife, then the doula just makes sure that she gets there, right? It's just really support. We're not saying you have to see our midwife. It's more like, hey, if you want to go see your own doctor, have at it, but like, let's actually do it. But we find that for the most part, all of the participants just want to see the midwife because the midwife comes to the NICU. And then there's really supposed to be a warm handoff at the time of NICU discharge to both community-based services as well as the medical home, which can be a challenge because there aren't always community resources or a medical home for everyone. So in some ways, you could make the argument that we're just pushing the cliff a little bit further out, but it will at least get through that immediate postpartum period. And then we're ascertaining outcomes at the 6-month period. Provision of healthcare, all the secondary outcomes I mentioned, as well as doing some qualitative interviews, and I'll share with you a few of those. So the primary outcome is time to receipt of postpartum care. So for those of you who are quantitative in the room, because it's a small pilot trial, we needed a continuous outcome. We're a little bit better powered to do that. And we called postpartum care if it had 3 factors. It needed to have a blood pressure check and treatment if needed, counseling around contraception and receipt if desired, and depression screening and referral and treatment if needed. And then there are this long list of secondary outcomes. So we have randomized 26 of our goal 40 since November. I will tell you, almost everybody says yes. I didn't pull up the consort document, but about 90% of people who are approached for this want to be part of this study. So the hard part for us is the control arm, right? Because the control arm doesn't want to be the control arm. And we and our 6-month outcomes are kind of underway. I wanted to tell you about our first study participant, who was really emblematic of how NICUs and postpartum care don't go together really well, typically. So this was a parent who had pre-existing cardiac conditions. So she was at high risk of cardiomyopathy postpartum. So she was her obstetrician had set her up for one of those earlier postpartum visits. All those things on the ACOG timeline that I showed, they had a touch point and they were going to have a visit, I think on day 11 or so. And her baby was a 32-week baby. And so the postpartum visit was scheduled on the same day that the neonatologists and the nurses had deemed was going to be the first day the baby could latch, right? Try to learn how to breastfeed. And that care time was scheduled for 3 p.m. And her postpartum care visit was at 1. Should be totally fine, right? And it's just about 8 floors down from the NICU. So even co-located, right? She gets there right on time. She waits 90 minutes. 2:30, she was like, oh no, I got to get up there. I don't know. She waited a little bit longer. I think by the time she got to the NICU, it was 2:50. The nurse had already hung the feed early. This woman was out of her mind angry. Understandably so, right? She tried to get her health care. She didn't get it. She tried to be with her baby for breastfeeding. It didn't happen, right? I don't know, the nurse had an admission, somebody was super sick, all the things that get in the way of the typical kind of care that we do. So it was really hard. And Naisha was there. So our doula, Naisha, was there and met her in the kind of entry area, gave her water, listened to her story, and then held her baby for her, read to her baby while she was pumping, and they got through the day, right? And we don't, our social workers would love to be able to do this, but they're taking care of 40 babies, right? So our doula was able to really be there. And our doula really is kind of like that knowledgeable grandmom that not everybody has, who's right there and really kind of focused on the baby. So we've learned a lot of lessons just kind of by our own observations, which include that blood pressure is a major issue, even for people who didn't have hypertensive disorders of pregnancy. We're detecting a lot of really high blood pressure. And then we're also detecting that our ability to get people seen who have really high blood pressure. So our midwife is fine. She'll do like 1 agent, maybe 2 agents. But when she's getting to the 3rd antihypertensive, she is at her limit. And so she needs the cardiologist to get involved. She works with an MFM as well. I mean, there's a whole team, all these people doing it out of the goodness of their heart because they believe in this. But we really do need a system of, adequate referral so that once things are identified, we're able to get them seen. And then also this I talked about that we don't have all the postpartum mental health care that we need. And then the other piece is having a doula and a midwife in our NICU is also, it's like having a fly on the wall. So they see all the things that we do and don't do with the babies, right? And all the things we say and don't say. And they hear all the, random comments that maybe residents make or attendings make or nurses make. They hear all the racist kind of side comments, making fun of people's names, all the things, right? And this is very traumatic for our doula and our midwife. And so there are really kind of opportunities for us to improve the culture of the unit by kind of welcoming folks in, right? And making sure that they're really present. The other thing the doula does, and she's amazing at it, is really helping families find their voice and to be able to kind of express their desires for their baby and kind of discussions around discharge timing, planning, all of that, really making that family centered and partnered. Here are some quotes that our participants have said. This is about Naisha, our doula. She wasn't judgmental. And like I said, she was more down to earth. So it's like, she's not going to be, well, why would you say that? And she's just what it is, relatable. She's relatable as far as experiences, just basically being in Philly. So this is really speaking to the shared lived experience and that, parents don't have to feel quite as guarded in their language or whatever their concerns are. When asked why someone would choose to have a doula in a next pregnancy, this participant said, they just care about you. Well, the ones I had showed me they cared about me. They barely knew me, and they took the chance to sit and get to know me and cared about my health, my mental, my physical, my emotion. So I would love to have had that experience throughout my whole pregnancy because I really didn't have that. Somebody who cared about me while I was carrying the baby. So really, again, focusing on the birth parent. About our midwife, this is about the kind of inefficiencies in our system. She's talking about her blood pressure medicine, and she said, let's see, she was the one who recommended it first, but I remember they only gave me a supply for a certain number of days, and she was able to give me the prescription to get the blood pressure medicine, or was she able to talk to the doctor? It was just certain stuff she was able to do that would have took 24 hours or a day, or I would have had to go to the ER to get it done. And she was just right there. So we have visions for what Pelican will look like in the future, including funding an on-site psychologist. CHOP has one at the Children's Hospital, but we don't have one at HUP next door to the Hospital, University of Pennsylvania. There are also other postpartum things that NICU nurses could potentially do, like finger sticks. So an example would be people who have gestational diabetes are supposed to do an oral glucose tolerance test in the first 12 weeks after giving birth. About 10 to 20% of people actually go through with that, even in the term well population. We could do that, right? You could just have glucola, remind parent to come in fasting, and then draw blood, drink the glucola, draw a few more bloods. I mean, they're sitting at the bedside anyway. And I'm not saying just to check the boxes. I did tell you I love checking boxes and getting A+, but that would really show that they cared. We as a NICU community care about the mother's health, right? Too, not just the baby's health. So I mentioned there are massive inequities in preterm birth. You already know this. And these are very similar inequities when it comes to maternal health. And so I see this work as anti-racist, right? You're going to have a disproportionate population, maybe not so much in Colorado based on what I just saw, but certainly in Pennsylvania, we have a disproportionate presence of Black families in our NICUs due to the high rates of preterm birth. And these are the same people who are at risk of bad maternal morbidity and ultimately mortality. And so if we can overcome some of the barriers to care by welcoming people who know how to take care of mothers into our units, we have a chance to make a difference and certainly show a model, because this isn't going to solve all of maternal mortality, right? Most people who die don't have NICU babies, right? It's just a higher proportion of people who are sick are going to have NICU babies. And so this is just one of the many efforts that's going to be needed to address maternal health. We have an anthropology PhD student who currently is doing a needs assessment in the CHOP NICU. You might ask, why didn't I do this at the CHOP NICU? If any of you have ever worked at CHOP, you'll know the answer, but it's really just that CHOP is a big, hard ship to move, right? To get a project like this done at CHOP would be really hard. So I wanted to show that it could work in a place that was really more confined and controllable. And so once we show evidence that it's working, then I can bring it to CHOP, as well as doing this needs assessment to show that parents of babies transferred into CHOP aren't getting the care they need, especially the non-special delivery unit inborn population. And so in conclusion, what can we all do about maternal health, right? So we need to think about, what is our sphere of influence? What can we do? What resources, money, and time do we have? Who are the personnel in your milieu that you can invite in? What is their disposition, their expertise, and their passion? And we lucked out because we were able to find all the people to be able to bring this program into our NICU. And I have a fellow named Kristen Scott, and he wrote a nice commentary in JAMA recently. And, he says it's going to take multi-pronged efforts, which are going to involve things like insurance coverage for postpartum patients, deploy birthing parent clinicians to novel settings, and ensure adequate payment for postpartum services. So I think it's going to be so many things. And there was someone who wrote a rebuttal to our commentary, and they were really focused on leave, right? That, maternal and parental leave is key. Not just, and, it's interesting that the rebuttal, and then we got to write the rebuttal to the rebuttal, which is always fun. So, they were talking about maternity leave. I said, actually, you need whole family leave, right? So that the mom can go get the care that she needs, right? So we're talking about parental family supports for making sure that we can support the health of postpartum parents. So I will close with gratitude, and I may be, I'm right on time, but I am happy to take any questions and discuss with any of you who have any interest. So thanks.
All right, let's open it up for questions. Okay, I'll get us started. So it seems so intuitive, like that this would lead to positive outcomes. Do we need a trial? Can we just do it?
Right. So that's actually what Naisha says to me too, my doula. She's like, we can't have a control arm. Now, part of it too is that this is really high touch, right? It's really resource intensive. So even if we didn't have a control arm, we don't even have enough people to do it for our 40-bed birthing unit with the one midwife that I'm paying 4 hours a week and the doula who is full-time, right? She would not be able to do this for everybody. So we sometimes have eligible people that we can't even approach because we can't actually support them the way they need to be supported. So I think that those of you who are learning and knowing about implementation science, and that's not the expertise I have, right? I'm more the idealist and the catalyst, but I think we really need people thinking about how to scale this, right? How would you pay for it? How would you make it possibly doable? How much of it could be virtual? How much of it could be, how do you scale something like this, right? And we're lucky in Philadelphia that, and maybe you have this here too, and the Department of Public Health has really good relationships with some of the payers, both the Medicaid managed care organizations, as well as the private insurers. And one of our leaders in OBGYN, Sindhu Srinivas, she's kind of a policy expert. And so she's kind of always in my ear about this, like how, yeah, it's obvious, Heather, but how would we actually pay for this? How would we actually do this? Having said that, sometimes we just do stuff and pay for it anyway, when we know it's the right thing to do. Child Life is an example at the Children's Hospital, right? Like it's just the right thing to do. Social workers are the right thing to do, right? Like there are certain things that aren't revenue generating that we do. And so ultimately we're just going to have to build the evidence. Now, having said this, the next probably, bigger study of this, I don't think we'll get away with randomizing people to a control arm. I think we'd probably have to use something else, like a step wedge approach, where you just kind of start at different times and just kind of do it in different, or some sort of cluster randomized control trial, because we have the other parents in the unit looking and seeing the support and wondering why they can't have it.
I mean, I've already told Heather that when it comes time to do the big multi-center trial, think of us here in Colorado, and we'd love to participate. Other questions? Oh, no, we have people on Zoom, so you got to use the mic.
This is really interesting. Thank you. My name is Liza Creel. I'm a health services researcher here on campus. I may have missed it, but you talked about depression screening. Have you thought about incorporating, and how you would incorporate, resource constraints aside, social needs screening?
Yeah, so we already do some of that. So I didn't put out all of the surveys that we have, but yeah, so Naisha also makes sure that she has this long needs assessment when it comes to, like, does your baby have a safe place to sleep when you go home? How are you getting here? Like, what do you eat? And so we have like a little bit of a Pelican slush fund, and some people who on the side just give us stuff. So, there are car seats that come in, and onesies and diapers. And, so we are kind of doing that. But again, this is why it's so high touch and resource intensive, that we would have to think carefully about it. So yeah, it's not the main. What I've learned, postpartum care is just the tip of the needs, right? There, I think we got funded by an agency that was interested in healthcare, which is why that's how we got there. But I think some of these other needs are just as, or maybe more important. Yeah, that's a good point.
Hi, I'm Kirsten Halstead. I work at Children's Colorado here. And until recently, I was the manager of our lactation program. And we're really fortunate. We've got a very large lactation team, which I think shows Children's commitment to breastfeeding and supporting moms in the NICU with that. And I was so excited to hear your talk, because for the last couple years, I've been, sort of noodling in my brain how we might be able to provide postpartum care to moms through our lactation team. And it happened when one of our IBCLCs just became a women's health nurse practitioner. So I'm wondering if that was ever a thought for you as you put this program together, to sort of center it around also lactation care. And Susan, I really would love to work with you if you want to move a pilot forward.
So it's so interesting and so wise of you, right? This is the natural, physiologic, important connection that's happening, right? And the touch point where, like, you're right, lactation experts are interacting with our birth parents more than many of the other professionals. So Naisha up there on the top left, she's not an IBCLC. She's many levels below, but is like a trained, lactation. She's not like, it's not an IBCLC. It's like she wants to be that, but she's training to do that. She's one level below, and I can't remember what that's called. So she is also really focused, but she does stuff like drives to the house and picks up the milk and brings it in, right? She does all that kind of doula level barrier overcoming work. So I think that there are ways to, you're right, deploy lactation. I mean, I'm not adding one more thing to lactation consultants, may not be the most popular thing depending on who you're working with. But I think also, are there people who can be kind of extenders to your group too, like either doulas or maybe more lay folks who have some expertise to really sit, because we also, breastfeeding is very racialized, and there's this long history of Black women providing milk for white people. There's a lot of mistrust around and most of our lactation consultants are white women. And so we have big disparities when it comes to breast milk provision. If you just look at human milk, it's not so bad because the donor milk uptake is pretty good for everybody. But if you look at mom's own milk at discharge, we have massive disparities. And I think, having someone from the community who can come and really support these parents and maybe not seem so extractive solely can be helpful. So yes, and yes, all of it. Yeah.
Quick question about the doulas. So does your hospital have any sort of criteria for doulas that they have to meet as far as, certification or education requirements or those kind of things?
So it's interesting. I hired Naisha as a research assistant. If you look at what her role is in the hospital, that is what it is. But we put in the IRB all the things she's doing. So it's not like she's not. When we first tried to hire a doula, we had trouble with any of the credentialing people. There are all these companies that the hospitals contract with to onboard people and to make sure they check all their certifications. And there was one outreach company or one company that was willing to do it for us. And they also get paid like 40% of the person's salary. I mean, it's unbelievable skimming off the top that happens. So we had hired, not Naisha, a different doula to do this role. And she got through about 2/3 of the mountain of paperwork and was getting calls in the middle of the night from somebody in another country who was checking this. And she was like, I'm done, right? And so there are structural problems to overcome. I think what this really means is that leadership needs to figure, they need to get on board, you need all of the stakeholders on board, and then they get to decide, right? So ultimately, they need to hear what all the kind of things to overcome. So we do have other words we can use, like community health workers, like there are other ways you can do this, but, Naisha did the DONA certification or whatever. So there are ways, but I think it is wise to come up with your criteria and then make sure the hospital is on board. But yeah, it's messy.
All right. Last question. Oh, okay. One more.
Okay. Mine is not so much of a question. I'm Andrea. I'm a NICU nurse here at Children's, and your talk was amazing, and I was so inspired. I am a former NICU parent, and 19 years ago, I had a very similar situation to what you explained with your first mom, who had to go to the ER because there was no help available in the NICU and had to spend hours away from my sick baby. And so I'm just sad that it's been almost 20 years and nothing has changed. But I'm inspired that you're working on it. I would love to help be a part of that if we were able to bring that here. But I do have to say the obstacles sound large. It sounds very complicated, the whole payment process and getting things approved. So I guess maybe you can help us with that if we get there.
Yeah. Luckily, you have a very smart woman at the front of the room. That's not me. That's Susan. So I do think it's going to and it's probably the answer to that will be different in every place. Kind of like your quality improvement collaborative, right? Some of the interventions will work in one hospital, but not another. And I think state by state, also the ways this happens will vary. So.
Last question.
Hi, thank you very much for your presentation. It was greatly appreciated. From a nursing standpoint, how did you see this project affecting the nurses' workflow, and how engaged or willing were the nurses to jump on this and help move it along and make it a successful program and project?
Yeah, that's so important. And I worried a lot about it, right? I love our NICU nurses, and they are incredibly protective of their days as well, but mainly their patients. And so we did a few things up front, nursing leadership, but that's not the same as all the nurses at the bedside, especially nights and weekends and all that. I mean, it's a whole different crew. And what I have, and maybe I'm wrong, and I'm willing to own that too. I think you have to hire the right people. So Naisha struggled in the beginning for a little while, and then she got to know the nurses' names, and then she made things a little easier for the nurses at times. And then she'd be rolling in at 11 o'clock on a Sunday morning with someone's milk. And the nurse, like, when you show you care about these families and the babies, not just the moms, but the babies too, because Naisha does that too. I think most, not all, but most NICU nurses eventually come around. And at this point, sometimes she'll get direct emails or texts from the nurses to come and see the parents. So now it's gotten to the point where the nurses are glad she's there. Same with social work. Social work wasn't super excited about this in the beginning. Like, are you pointing out all the things we can't get done? Like all that. Same idea though. Now they see this as just, they're just so excited and they're so sad when someone gets randomized to the control arm. So I think it's on us and others who hire people to hire the right people and try to, partner as much as we can up front, which we did. But, again, the random nurse who's not on the committees, who's not, she's not going to be aware of this happening. And then there's this random person at the bedside. I tried to communicate, like, imagine it's grandma. Right? Can you picture the doula as grandma? Not everybody has the high functioning grandma. We wished everyone did, right? So, and grandma's going to be annoying sometimes and ask all the hard questions, right? And so same with the doula, right? And so I think that's how I've tried to sell it. But again, I'm not sure that would work everywhere. That's a really good point.
Thank you, Heather.